California Institute for Mental Health, in collaboration with the Alcohol and Drug Policy Institute and the Integrated Behavioral Health Project, we'd like to welcome you to the second of a 6-part webinar series, Integrating Primary Care, Mental Health, and Substance Use Services. The goal of this webinar series is to provide information on critical policy, design, financing, and practice issues related to integrated care from the California and national perspective. The webinars will cover best practices and emerging practices in the field, with presentations from state and national advocates, researchers, and practitioners. These webinars are free and open to all and are held from 12 to 1:30 p.m. on the dates indicated in the schedule, which is posted on the CIMH website. To view the schedule or to register for future webinars, please go to the CIMH online learning link on the CIMH website. Please note that you must register online for every webinar you wish to attend. Webinars will be recorded and posted on the CIMH Integration Initiatives webpage following each event. All this information I've just covered, I'll go over again at the end of the presentation. Again, good afternoon. My name is Lori Alexander. I'm a behavioral health consultant with CIMH and the facilitator of today's webinar. The outstanding presenter for this session is Dr. Jürgen Unutzer. Dr. Jürgen Unutzer is director of the AIM Center, which stands for Advancing Integrated Mental Health Solutions, at the University of Washington, and he heads up the Impact Implementation Program, which is part of the AIM Center. He is professor and vice chair of psychiatry and behavioral sciences at the University of Washington and chief of psychiatric services at the University of Washington Medical Center. Dr. Unutzer is an internationally recognized mental health services researcher who works with national and international organizations to improve care for common mental disorders such as depression. Before I turn things over to our presenter, a brief word on how today's webinar is structured. Dr. Unutzer will present for about 60 minutes, and then we'll have about 20 minutes for audience questions. Due to the limited time available and the large number of audience members, we will only take written questions for the presenter. To send in a written question at any point during the webinar, simply type your question and click Submit in the dialog box. We've had a wonderful response to this webinar with well over 200 participants signing up, so we apologize that we may not be able to get to all of your questions during today's webinar. Following this presentation, we will create an FAQ bank on the CIMH website to address as many of your questions as possible. And a final bit of housekeeping. If you experience any technical difficulties during the webinar today, please contact May Chan at mchan@cimh.org. Again, that's mchan@cimh.org. Thank you again for joining us today, and now we will begin our presentation on the evidence base for models of integrated care. Dr. Unutzer?
Yeah, thanks for the nice introduction, Lori, and good afternoon to everybody. I'm here in Seattle, Washington, and I'm going to just say a little bit about myself, a little bit of disclosure. As Lori mentioned, I work at the University of Washington, where I'm a professor and vice chair in the Department of Psychiatry. I have grant funding for various projects from federal and foundation funders. I have contracts with a health plan here in the state of Washington and with our King County Department of Public Health, and I do some consulting work and advising. I also had a center here at the university that is focusing on advancing integrated mental health solution that really builds on some 25 years of research and practice in this area here at the University of Washington. The objectives for today's presentation, first of all, to review the evidence base, the research evidence base for integrated mental health care, to think a little bit about what do we know from research and what do we not know yet, to summarize what I think are the core principles of evidence-based approaches to integrating mental health care, and then to think a little bit about how do we bridge the gap between what we know and what we don't know yet, and what might be some strategies for adapting and implementing evidence-based approaches in what are often pretty diverse settings. I think you had a very nice webinar presentation earlier, the first one in this series from Barbara Maurer and Connie Weisner, and they made a very nice case for why should we be integrating mental health and the rest of healthcare services. And I'm not going to say a lot about that. I'm going to just review a couple of things on that from my perspective. So in primary care, one of the most obvious reasons to think about treating mental health conditions in a primary care setting is because that is where our patients are. I'm going to show another slide on this in a minute, and that will make the point that primary care is really, for the vast majority of adults at least, who are receiving mental health services, they're not receiving them in specialty settings. They're actually receiving them in primary care settings today. On the other side, we have become increasingly aware, and I'll speak more to that at the end of this presentation today, that in the mental health care specialty settings where we treat patients with severe mental disorders, those patients often receive very poor medical care, and there is now very good research data that suggests that our patients in these settings are dying an average of 25 years earlier than those without severe mental illness. And it's not they're dying from things directly related to their mental illness, such as suicide. They're dying from untreated or undertreated medical conditions, such as diabetes and hypertension. And so that really challenges us to think about how do we address the medical needs of those patients. So we can really look at this integration thing from both sides. This is a very busy slide, and we'll make available to you a copy of all these slides. So I won't read through it. I'm trying to make the point with this slide that on the notion of trying to integrate mental health and primary care and the rest of health care, I think we're well beyond the tipping point. This is an enormous effort nationally now, and this is a slide that lists just a few of the initiatives, some of the initiatives that I'm aware of or that I've been involved in some way or another that have tried to advance the agenda, building on some 25 years of research that the National Institute on Mental Health has really funded, but many, many national, regional, and local initiatives that really have tried to advance the state of the art in this field, including the program that's getting us together here today, that's supported by the California Institute on Mental Health. So there's a lot of activity in this area, and I can't summarize all of that in one presentation today, but I just wanted to point this out. This is not something that we just started thinking about yesterday. As a clinician, I would say for me the most compelling reason to think about integrating mental health and substance abuse treatment with the rest of healthcare is the fact that the vast majority of our patients who have mental health and substance abuse problems, that's not their only problem. They have that in the context of a whole number of chronic medical diseases, heart disease, diabetes, neurological disorders, either neurological disorders by themselves or many of our severely mentally ill clients and neurological disorders that are really side effects caused by long-term treatment with neuroleptic medications. We have patients with cancer. There's tremendous overlap between the emotional pain that somebody with a serious mental illness suffers from and chronic physical pain. And we often, in the mental health side, think that this is all mental, emotional, but there is a lot of untreated or very poorly treated physical pain in this population as well. And then a lot of health risk behaviors, smoking, obesity, physical inactivity, those are huge challenges in our mentally ill clients. And in the corner of this slide, at the bottom right, there's a little picture of a chicken and an egg. And that is just to really make the point that even for a good clinician, for somebody who's worked at the interface of mental health and primary care for most of my career, it's very challenging for me when I see a client who has depression or anxiety in the context of one or two or more of these physical problems. It's very hard to really tease out what's driving what and what's influencing what and what's causing what. So making an arbitrary definition there between the mental and emotional and the physical, often really doesn't serve our clients' needs very much, because the patient is the same patient. We might divide them up into a mental and a physical box to serve our needs, but that's not how the patient feels. And the next slide makes this point in another way. So I think that we now talk a lot about patient-centered services and patient-centered care. But I think if we're really honest, what we provide to most of our clients is not patient-centered. I would call it agency-centered, in that we organize our services into what I would call a couple of silos. I grew up on a farm, so I like agricultural metaphors, and this slide sort of shows that we provide services in primary care. We provide the healthcare services in community health centers. We provide mental health services in specialty mental health centers. We provide alcohol substance abuse treatment, yet in other settings. And then there's a whole range of social services, vocational services, other community-based services that our clients really need. And all of these services are really not well integrated today. And we have many, many clients. And I've never met a client who says, I wish you guys kept better secrets from each other. All of our clients are saying, don't you guys talk to each other? They're bringing up these issues in all these settings, and everybody says, what is my part of that? And that just doesn't add up to very much for most of our clients. So that's my very brief effort to try to say, why should we do a better, more integrated, more patient-centered approach? And so I have a little schematic here that sort of helps me think about what do we do as we move towards a more integrated approach to care. I'm going to start at the bottom of this. And I would say sort of the worst situation we could have is to have all these siloed services and to have us compete with each other. To sort of say, well, if it's mental, it's got to be in this silo. Why do they want to do that in primary care, or vice versa? The more typical thing I think that we see is not that we are really competing with each other. The more typical thing is we all exist in parallel, and we don't work with each other. We might consult each other, but that often doesn't really work very well, because if I make a referral from a primary care center to a mental health center, the data is very clear that about half the time, 50% of the time, the client may not go. And often they might go and have 2 or 3 contacts, and then they'll fall through the cracks and they'll be back in the primary care setting. And the reverse is also true when we try to get good medical services for the clients we have in the specialty mental health settings. So the next level up in terms of integration might be that we actually say, why have separate facilities? Let's co-locate our services. Let's have a mental health provider in a primary care setting, or let's have a primary care provider in a mental health care setting. And I think that's a good start. Bringing people together in a geographically co-located way is a very nice start, but it often is just a start, and it really isn't ultimately where we need to go. The argument I'm going to make is that what we really need to do ideally is not just be co-located, but to actually collaborate effectively. And I'll try to sort of point out a little bit more in this presentation what I really mean by that. So now let me turn to what Lori had asked me to talk about, and that is reviewing the research evidence for much of what we work on in this area. So this is one slide that tries to summarize this in 3 bullets. I think the strongest research evidence that we have in this area today is for an approach that we're going to call collaborative care. And that has been shown to work very well, better than usual care for common mental disorders, things like depression or anxiety disorders in a primary care setting. There's also, I think, very good research evidence. You heard a little bit about that from Dr. Weisner on the earlier presentation, and I think you were going to have a webinar coming up on the SBIRT model on screening and brief interventions for alcohol abuse in primary care. There is some current research that extends those approaches to other types of substance abuse, but there's not a lot of research data behind that at this point. I think when we look in the flip side of what's happening in primary care on the specialty mental health care setting, there is starting to emerge research evidence for ways to improve the medical care for patients with severe mental illness in mental health centers. But the research evidence base for that is, I would say, 10 to 20 years behind what we know about how to improve mental health services in primary care. That's a very much an emerging field, and I don't think we have a lot of very clear evidence about exactly what to do there. So let me start on the primary care side, and I'll finish the presentation today by looking at the mirror of that and saying what can be done on the mental health specialty side. So let me say a little bit about behavioral health, mental health care in primary care settings. This is a slide that you may have also seen in Barbara Mauer's presentation. This is from a very large study that looked at the prevalence and treatment of mental disorders nationally in the United States. It's a couple years old, but I think it's still quite up to date, and it's very telling. So what this study did, this is a study that tried to establish national prevalence rates of common mental disorders and to look at if people have these disorders, are they getting treatment and where are they getting their treatments? And what they found is that of all the people that the survey picked up as having a mental disorder, only about 41% of them were getting care at the time of the survey. So there's many people who have common mental disorders that are not getting active treatment. Of the people who are getting care, so a little bit less than half, a little bit more than half of those said, my care is being provided to me in a general medical primary care setting. And only 44% of those who are receiving treatment said, I'm being treated by a mental health professional. I'm getting my services in a mental health specialty care setting. So that's, I think, an important thing to point out. And this actually is a fact that has not changed since it was first studied in 1980. And Daryl Regier, who led that study in 1980, which this here really just replicates, titled the paper he wrote about this something like primary care is the de facto mental health delivery system in the United States. Sort of saying that it may be that it's not a judgment on if this is a good thing or a bad thing. It is what it is. That's actually where most people go to get their mental health care. So I'm going to depart from this. Having said that, it's not easy to do that in primary care. And this is a cartoon that makes the point that a very large survey of several thousand primary care providers from 60 U.S. community did a couple years ago, where they asked primary care providers about their satisfaction with the ability to help their patients with different kinds of needs. And 66%, the number one complaint in the survey, 66%, two-thirds of primary care providers said, the biggest problem for me is I have very poor access to mental health care for my patients. So the cartoon here says, we couldn't get a psychiatrist, but perhaps you'd like to talk about your skin. Dr. Perry here is a dermatologist. Just to make the point that from our colleagues in primary care, from their perspective, this is a huge challenge. They're very unhappy with their ability to get help with their patients who need mental health care. A little bit more data about research that's been done in primary care. We've really best studied common mental disorders, so things like major depression, clinically significant severe depression. And when you look at the adults, the 5 to 10% of adults in primary care settings who have major depression, you'll find that about half of them are receiving some treatment. The other half are really not getting any treatment at all. The groups that are at the highest risk for not having treatment in primary care are older adults, adults from ethnic minority groups, and there's a few other vulnerable populations. So, for example, if you're an older African-American man who goes to a primary care provider with a really severe major depression, you are 2 or 3 times less likely than if you were a younger white woman showing up in that same clinic. So there are some things that put some of our patients group at particularly high risk for not being recognized or treated. If you look at all the patients who are receiving treatment for depression in primary care, as an example, you'll find that only 20 to 40%, so less than half of those who are being treated actually show a substantial improvement in their depression over 12 months. What we do see in primary care over the last 10 years is tremendous increase in the use of antidepressant medications. And in fact, primary care providers today prescribe antidepressant medications to some 15 to 20 million people a year. About 75% of all antidepressant medications prescribed in this country are prescribed by primary care providers, not by psychiatrists, not by psychiatric nurse practitioners. So there's a tremendous increase in treatment, but we see a lot of these patients dropping out of treatment early. They don't get treatment long enough, and sometimes they'll be started on a very low dose of a medication, and they may stay on that low dose for a long, long time and never really get much better. So those are some of the challenges we have with treatment in primary care. What we see very little of, we see very little use of evidence-based psychosocial treatments, so psychotherapies, counseling treatments. It's very challenging to try to give patients in primary care access to those kinds of treatments, and they can also be very effective. So what would it take to help the primary care sector do better with the common mental disorders? And there is actually a lot of research on this, and I'm going to just summarize 30 years of research in a kind of a simplistic way on this slide. So there was a lot of research early on that said, what if we just do more systematic screening for mental disorders? What if we train our providers, our primary care providers better? What if we develop good treatment guidelines for them? What if we make it really easy for them to make referrals to mental health providers? And I'm going to tell you that there have been, on any one of these things, a number, 10 plus studies done on each of one of these points to see, will that help improve outcomes? And it turns out these are all good ideas. They may all be helpful, but by themselves, they're really not sufficient to try to help improve care. Even making really good referrals available, so making it really easy for the patient to go to a mental health center, it turns out that's very challenging. Half the time the client doesn't really go, and often when they go, it turns out when you measure the outcomes, they don't do that much better when they got a referral to a mental health center than they were doing in primary care. I would say at this point, the strongest research evidence we have is for a model of care we call collaborative care. And there's a reference on this slide that is that sort of looks at some of these 3 points on this slide. And I recommend that. This is a literature review that Ben Dross and Michael Schönbaum and I put together for the President's New Freedom Commission a couple of years ago. I think it's still a pretty good reference. Now, what can we say about collaborative care programs that are working well? There is another nice reference. Simon Gilbody, who's a British researcher, published this in 2006, and they reviewed 37 randomized controlled trials that showed that collaborative care is substantially more effective than usual care in primary care when it's done well. And they summarized sort of 3 main components of a successful collaborative care model. The first one is the notion of providing active care management. And I'll speak more to this, but basically that means that we don't just start a treatment and let the patient walk out of the office because they may never come back. They may fall through the cracks. We really track patients closely. We do a lot of close follow-up. We make sure they don't fall through the cracks. The good collaborative care programs all make smart, systematic use of evidence-based treatments, and that can be medications and or counseling and psychotherapy treatments. They also all provide psychiatric consultations that is focused on those patients in primary care who are not improving as we might like to see them. So there is a psychiatrist designated not to see all those patients, but to be available to consult on those patients who are being treated in primary care who are really not improving as expected. So those are some of the things that that Gilbody and colleagues pulled out of reviewing all these randomized controlled trials and say, what are the ones that really are successful have in common? I'm going to talk a little bit about one of these 37 trials, and that's the IMPACT study. This is a trial I had the pleasure to lead about 10 years ago with funding from the Johnny Hartford Foundation and the California Healthcare Foundation, the Robert Wood Johnson Foundation, and the Hogg Foundation for Mental Health in Texas. In this study, we worked with 1,801 patients who had significant depression in 18 primary care clinics in 5 states. And we tested a collaborative care model, and we compared that to usual primary care. And the next picture here says a little bit about how this collaborative care model worked. Basically, it takes off from a concept for good chronic illness care that was developed by a colleague of mine here in Seattle, Dr. Ed Wagner, who said, what does good chronic illness care look like? Well, to enable good care for things like diabetes or high blood pressure or congestive heart failure, we need to think a little bit about how can we help the patient become a more informed, more active patient in their treatment, and how can we help the primary care provider develop a more prepared, proactive approach to the treatment, because primary care often is much more reactive. It's set up, the patient shows up, you do the best you can on the day that the patient is in, and then the patient goes away. And in this approach, we are going to try to be a little bit more organized, a little bit more proactive. And to make that happen, we trained in each of these 18 clinics a behavioral health specialist, and that could be a nurse, a clinical social worker, it can be a psychologist, and we've done it with all those types of professionals. So each of these 18 clinics, we trained a behavioral health staff member to function in a role that we call the depression care manager or the depression clinical specialist. And the role of this care manager was to work with all the primary care doctors in the office, and when they diagnosed a person with depression, the primary care doctor would introduce that patient to the care manager, the depression care manager, and say, I'd like for you to work with this care manager and me, and together we're going to keep track of this depression. And the care managers did a couple of things. They were taught how to do some basic patient education around depression, around other common comorbidities such as anxiety and other things like that. We taught them to use a very simple 9-item rating scale called the PHQ-9 that measures the 9 core symptoms of depression every single time they had contact with the client. And we use that to help guide the treatment. We say if patients are getting a lot better on this, their symptoms are getting better, we know we're on the right track. If they're not getting much better, then we have to make some adjustment in treatment. And each of the teams had a psychiatrist assigned to it who would not come on site and see all those patients, but who would once a week go over all the patients that were active in this clinic and make treatment recommendations on those patients who were not improving as expected. It's very different from what we would have in usual care, where as a psychiatrist I might be asked to see the occasional patient. Here I was asked to comment on everybody, especially those patients who are not improving, but I might not see most of them in person. So that's the basic approach. And another way to summarize that is we really have 2 new team members introduced here. We have in the primary care setting the behavioral health care manager and a consulting psychiatrist. And we have 2 new processes, and I'll say a little bit more about each of these in some subsequent slides. So the first process is we're going to be a lot more systematic about diagnosing and tracking outcomes. We're going to follow an approach that I'll say more about called measurement-based practice. So every time we have a contact with the client, if what we're treating is depression, we're going to measure how bad is the depression. We're going to be asking systematic questions about all of the symptoms of depression, which include depressed mood, loss of interest and pleasure in things. We're going to ask people about their appetite, about their sleep, about their energy level, and we're going to measure that on a scale. And if we don't see much change, much improvement on that, we're going to have to take a step back and say, we're missing something. This person isn't getting better yet. What else do we have to do to change the treatment? And that leads to the next process. We use the process called stepped care. So if we didn't see patients getting better, we would say, we need to make a consultation and we need to adjust our treatments. And so what we did in this model, we made lots and lots of treatment adjustments. So if the patient was being treated with an antidepressant medication and that was not working, we might increase the dose. If that's not working, we might increase it again. If that's not working, we would switch to another medication, or we would introduce an evidence-based psychotherapy. And at this point, you could then introduce cognitive behavioral therapy, you could introduce problem-solving treatment, you could introduce behavioral activation, or any other evidence-based psychotherapy that is a reasonable treatment for this. And then we would say, let's let that go for about 6 or 8 weeks. And if the depression isn't getting better, it's a nice thing that we did this, but the patient, it is what it is. The patient isn't better. Let's make a new treatment plan. So in a very systematic way, for an entire year, we would just keep chipping away until we got a person better. If you looked in the usual care group, all of the usual care patients, the vast majority of them got started on an antidepressant medication by their doctor, about 70% of them. About 25% got referred to a mental health specialist. So they were all getting some treatment, but the treatment was not adjusted very much. Many of these patients got started on a med and took that med for the entire year, but never really got all that much better. And so in a stepped care model, you wouldn't tolerate that very long. You would say 8 or 10 weeks. It's good that the patient is taking the treatment, but they're not better. They're not much better. We need to make a change. And the consulting psychiatrist is really primarily used around this making a change. They would be called in to say, what is a change? What is the next change in the treatment strategy? They might also say, gee, this is a complex case. I've talked about this person a couple of times. I can't really tell. I need to see that person and make my own evaluation. So about 10% of the patients in this trial were actually seen by one of our consulting psychiatrists. I'm going to show just a couple of data slides from this approach. So we did this study in 18 clinics, but they belong to 8 different healthcare organizations, so 8 different medical groups in a sense. And what I'm showing you here is the likelihood that one of those patients got 50% or more improved in terms of their depression 12 months after we started them in the project. And this is a way that is commonly used in depression research to say that's a substantial improvement. If their depression symptoms are down by 50% or more, that's a substantial treatment response. And this slide shows you at each of these 8 healthcare organizations we worked with, half of the patients were in a usual care control group, and the other half got the collaborative care program. Same doctors, same group of patients. Half of them got a care manager, and we did this systematic step treatment. And as you can see here, across the board in all of these 8 organizations, we had significantly more people get better in the collaborative care group than in the usual care group. In fact, we more than doubled across the board the likelihood that someone's depression was going to be substantially improved 12 months out compared to the usual care. Now, there's a circle drawn around one of these organizations, and that is just to help me make a point. This organization, number 7, is a very interesting organization. This is a very large health plan in California. They had one of their clinics as a participant in this study. And this is an interesting organization, and they had made a couple of years earlier a big commitment to placing behavioral health staff in all of their primary care clinics. So in this clinic, they actually had at each floor that the primary care doctors worked 1 or 2 behavioral health professionals working side by side with the doctors. They had a co-located model. And when they came and talked to me about joining the study, I said, I don't think that you can really be part of this because you already have what I'm trying to do. And the medical director and others talked with me about this some, and they said, well, not so fast, they said, because we're not doing a lot of this other stuff you're talking about. We're not doing the measurements. We're not really collaborating so much. We have more parallel play going on. The behavioral health people are doing their thing. The primary care people are doing their thing. Yeah, they're on the same floor. But let's try this anyway. So in this site, number 7 here, everybody who was in usual care had a primary care provider and an on-site behavioral health provider. And the interesting thing is, even there, using the more systematic model, we more than doubled the outcomes they got from their usual care approach. So just co-locating somebody doesn't necessarily do the trick, and I'll come back to that in a little bit. We also looked at not just at mental health, we looked at physical functioning in these patients. And what we saw is the patients who had the collaborative care model, the impact care model, they had significant improvements in their physical functioning over a 12-month period, where the people who were in the usual care group actually had a slight decline in their physical functioning. And then finally, we looked at healthcare costs. And we had an interesting experience there that when you look 4 years out from where people start in the project, those folks who had gotten the collaborative care program actually had substantially lower total health care costs over the next 4 years, about $3,000 less per person. And we saw them using fewer everything, fewer inpatient medical, outpatient medical, fewer outpatient mental health costs. So treating the depression effectively in primary care actually helped reduce a whole bunch of their other health care costs. So this was a very successful effort. We were pretty happy with this. I think our patients were very happy. We had very high patient and provider satisfaction. Several of the sites that did the project with us continued the model after the study ended. And they have since been a number of studies that have taken this basic model and applied it in other settings. So there are a couple of studies that have done it with cancer patients. These are all actually California-based studies. They were all done at USC, County USC Hospital with a mostly socioeconomically very vulnerable group of patients who had both cancer and depression. There's a study in here that is for patients who have cancer and who have diabetes and depression. There was also a San Diego-based study with Latino-speaking, Spanish-speaking depressed diabetics. And every one of these studies has used the same basic model and showed that you can substantially improve depression outcomes using this collaborative care model. There is a replication study in here. One of my colleagues here in Seattle has done this with depressed adolescents in primary care. And there is just recently been published a study with heart disease patients who have depression. And all of these studies are essentially replicating that this is a smart way to try to treat depression. There's also a number of national bodies that have taken a look at this literature. The President's New Freedom Commission, the Institute of Medicine. There is a nice report out from the National Business Group on Health, and then SAMHSA in its Registry of Evidence-Based Program of all endorsed this basic model of care as a superior approach to treating common mental disorders such as depression. Now, so that's nice. There's a lot of research behind this. I'm going to share with you a little bit efforts we've undertaken in the last couple years to say, how do we move this beyond research? Because even though we had done it in 18 clinics, there's thousands of clinics. And what does it look like when you don't have research funding behind it? Does it still work? Can you really scale this? So I'm going to share a little bit experiences we have over the last couple years. We have worked with some support from the Hartford Foundation to help train some 4,000 clinicians in over 500 clinics around the country in the basic impact model. We've also done a really nice initiative with funding from the Hogg Foundation, and that was under the leadership of Lori Alexander, who is moderating our call today, and more recently with another Texas-based foundation called the George Foundation, where we've worked with community health centers in 9 communities in Texas to help them establish this kind of an integrated care model. And I'll say a little bit about another large program that we've supported in Minnesota called the Diamond Program, where there are 9 health plans that work with 25 medical groups and have implemented this kind of a program in some 90 clinics in Minnesota. Just to give us a little sense of, do we have data that substantiates that this works even outside of a research trial? So just to point out, like I said, that we have actually trained some 4,000 people around the country in this, and we have trained all kinds of different professionals. We have trained psychologists, we have trained clinical social workers, we've trained nurses, and a number of other therapists working in the sort of core role as the behavioral health care manager. The Diamond Initiative is an interesting project, and I'm going to point you to a website if you'd like to learn more about this. They have some wonderful video testimonials from some of their providers and their patients on their website that I really recommend if you'd like to learn more about that. This is an interesting project where the Institute for Clinical Systems Improvement, or ICSI, has gotten together 9 of the bigger health insurance plans in Minnesota and 25 medical groups that bring together 90 primary care clinics. And they have worked together to establish a billing code for this kind of evidence-based depression care management in primary care that would support clinics implementing this model and creates a case rate-based payment for actually providing this kind of care. This has been going on for several years, and they routinely report the depression outcomes to a statewide organization called the Minnesota Community Measurement. The website for ICSI is on the slides, and I'd really suggest that you explore that a little bit. There's some wonderful, like I said, data and also testimonials on there. Some of the early data that was just recently published from this effort is that they're getting pretty much exactly the same results in this very widespread real-world replication that we got in the original study. In fact, the response and the remission rates in the DIAMOND project look, if anything, a little bit better than what we saw in the original IMPACT trial. I'm going to say a little bit about the Hogg Foundation-initiated Integrated Care Initiative in Texas, and Lori could tell you a lot more about that because she really led that effort, and we helped with it. This was an effort to help community health centers and FQHC and several urban and rural settings in Texas implement a model like this. And I'm going to just show you a little bit of a data slide. This is a typical center. This is a center that had 3 part-time licensed clinical social workers working in a community health center in the care coordinator, care manager function. What they were able to do is to get very high rates of improvement. Over 60% of their patients were substantially improved in terms of their depression and anxiety symptoms. They accomplished very high rates of follow-up. One of the things they taught us is that you can do much of this work by telephone. So much of the care manager's work was not bringing the patient into the clinic. In fact, you can see here, on average, these clients had 13 contacts with the care manager. Maybe had 2 or 3 visits with the primary care doctor, but behind that there would be 13 contacts on average with the care manager. 3 of these contacts, 3.3, were clinic visits, and 10 of them were telephone calls. So I think we learned from that that you can use the telephone in a very effective way to make sure people keep moving along. People don't sort of get stuck, don't fall through the cracks. And every one of these sites had a consulting psychiatrist behind it that would log on to this tracking tool that we established for this project and systematically go through with the care manager once a week what needs to be done to help further improve things. So a couple of lessons we've learned from all of this work. I think the first one is a clinical one, and that is oftentimes whatever it is that we start as our initial treatment, it's good, but it's not good enough. So we have to have systems in place that help us systematically adjust treatment if patients are not getting better. And we use an approach called measurement-based stepped care. That is, in order to know that it's time to make a change in treatment, we have to measure, is the patient getting better? And there are some very simple tools in depression and anxiety, even for bipolar disorder and other common mental disorders. There's very simple tools that we can use to systematically measure that. And then when they're not getting better, we have to say, what's plan B? We've also learned a lot about collaboration. We've learned that you really do need an integrated, interdisciplinary team, that co-locating a behavioral health provider with a primary care provider, just putting them close to each other isn't quite where it's at. We really need to do integrated work, shared work, where they work very actively with each other. They refer to each other when they talk to their clients. And that's not a natural state. Oftentimes, people are much more comfortable doing their thing and really doing parallel play. And that's something that can be taught, though. We've learned a lot about practice change. Very hard to get somebody to change their practice. You all who are running practices know this. So I have this slide here that reflects what I've heard from people we've asked to try to implement these programs. They're saying, whoa, it's sort of like you're asking me to change the oil in the car while I'm driving it. I can't just stop my operation and sort of start over. One guy said, it's sort of like you're asking me to, we're flying an airplane and you're asking me to remodel this thing in midair. You'd like to be flying with something very modern. I'm flying in this DC-6 here, or whatever that thing is, and I can't just stop the whole operation. So it has taught us a lot about what it takes to help a practice in terms of supporting them, implementing, making some of these changes. It requires a fair amount of work. A few financial points. There are lots of ways in which you can finance this kind of an approach. In some ways, the easiest approach is if you're in a capitated setting. You can just find your way to or using your resources in this kind of a way. The DIAMOND model in Minnesota, which is essentially a case rate payment, where 9 health plans are using that approach. That's been, I think, quite successful. We have a model here in Washington that uses more a performance-adjusted contracting model with a health plan, and I'll say a little bit more about that. Overall, I would say, just as we have all these siloed services, those siloed services are driven from some very siloed funding streams, and that can be a huge barrier. But just thinking that having it all integrated in one health plan isn't often the entire answer. So big organizations like Kaiser or Group Health or the VA, they may all be under the same name, but those of you who work in organizations like this, you know that even in these organizations, things can get pretty siloed out. So there's a guy in charge of the pharmacy budget, someone else in charge of mental health, someone else in charge of outpatient primary care, somebody else is looking over the inpatient budget, and very quickly all of that stuff can get very siloed. So those are some of the challenges you have to take on if you really seriously want to implement these kind of integrated approaches. I'm not going to say much about substance abuse in primary care. I think you heard a little bit from Dr. Weisner about this, and I think you'll have another webinar coming on SBIRT. I'm just going to point out that there really is now a pretty substantial literature, over 25 controlled trials that show that there are some very systematic approaches to addressing at least alcohol, high-risk, at-risk drinking and alcohol abuse in a primary care setting. So I really, for those of you, and they can be combined in a very nice way with approaches to treating common mental disorder. This is a slide that I put together that we're using in a program we're supporting in Pittsburgh and in Alaska, where we have said clinics that are doing good care management for depression and SBIRT, you can really bring these two things together because there are a lot of parallels. Both approaches have ways of systematically identifying the patient. There are some patient education and engagement strategies we use. You need to do close follow-up and a lot of motivational interviewing and behavioral activation on both of these approaches, so there are some nice parallels there. And then you can sort of go down the list. So this is a kind of an approach that we've used to help think about if we're doing both alcohol and common mental disorder treatment in primary care setting, you can pull those two models together and come up with something that's a little bit more integrated that actually feels like it's somewhat integrated to the clinic and the patient. So this is really just a conceptual overview. And I won't go through all the details. You have access to these slides, or you will have, so you can take a look at that, and I'd be happy to talk about that with you. I'm going to move us along and talk a little bit about more serious mental disorders, sort of moving beyond depression, anxiety. I'm going to speak a little bit about a program we have here in the state of Washington called the Mental Health Integration Program, and we have a website for this program that's on the slide, so I encourage you to take a look at that if you'd like to learn more about that. The notion with this program, this is a program that serves a safety net population in our state. These are clients who are in our state's general assistance program. They're very low resource clients, lots of socioeconomic stressors and vulnerability. Somewhere between 20 and 35% of these folks are homeless. And we have a number of other in western Washington here in King County. The county supports us caring for a number of other high-risk safety net populations in this kind of an integrated way. When we take a look at who these clients are, what we find is there's tremendous comorbidity. These are often folks who don't just have a physical problem, but they have sort of a wicked combination of alcohol and drug problems, mental illnesses, and the whole range of mental illnesses, really, and some 2 or 3 chronic physical problems. In addition to that, we see lots of chronic pain, substance abuse, prescription narcotic misuse is a big problem, and then, as I said, homelessness and unemployment and poverty. So a very high-need, high-risk population. And when we look at how do we best care for these folks, we realize that nobody has all the answers for these complex patients. So we devised a kind of an extended version of the primary care-based collaborative care model that's summarized on this slide. So everything on this slide that's above the green bar happens in primary care, happens in a community health center. And we have a network of community health centers that is organized by the Community Health Plan of Washington here in our state. Over 100 clinics participating in this effort at this point. And in every one of these clinics, we have the patient, the primary care provider, and we've systematically added in and trained at each of these sites a care coordinator. This is sort of the behavioral health care manager role that I spoke about earlier, and a consulting psychiatrist. And that psychiatrist, again, is not there to see all those patients, but is there to systematically consult on those clients who are not getting better. And then we realized with these complex clients, there's no way we're going to meet all of their needs in primary care. We can actually, it turns out, meet a lot of them in primary care. And they like that because that's where they get care for their other medical problems. But there is about 20% of these clients where we really do the best we can using sort of the enhanced primary care approach, but we really can't quite make it happen. So we have developed, each of these primary care clinics develops relationships with a mental health center. And at any given time, somewhere between 20 and 30% of the clients are actually getting their mental health needs met in a mental health center, but it's coordinated very closely with what's going on in primary care. So again, that things don't fall through the cracks. Similar efforts in this program is coordinating with other social services, with the state vocational rehab program, and then with chemical dependency and substance abuse treatments. So really an effort to try to build a coordinated approach to meeting all of these safety net patients' needs. And what we have found, and this is another typical, a little bit of a picture of what a typical caseload looks like. So we have a clinic here, and I'm blocking out the names. This is just to illustrate what we do. We have a clinic here that has 2 licensed clinical social workers. One of them has a caseload of 70 active clients. One of them has 86 clients. We keep very careful track of people's depression severity, their anxiety severity, and a number of other parameters. And what we find that even in this very high need safety net vulnerable population, we have 60% of patients who have been in treatment for 10 weeks or more have a substantial improvement, more than 50% reduction in their depression and anxiety symptoms. That's really a phenomenal outcome. And again, to make that happen, you need to have all these pieces. You need to really measure and systematically track. And over 50% of these clients have had one of our psychiatrists really look at their care when things are not improving. That's a very important part of this. So what are some of the core concepts to really make this work well? I'm going to go kind of fast through these next couple of slides because I've made some of these points already. This is just sort of to summarize. So I think, again, you really need multidisciplinary practice, but not co-location, really collaboration. Because there isn't any one of us, any one professional who can meet all these people's needs. You need to have a population focus. So you really have to say all the people who started treatment, do we know where they are now? You've got to make sure that people don't fall through the cracks. And we use a tool called a registry or a care management tracking system that I'll speak a little bit more about to make sure that that happens. You also have to bring to it this notion that just like in physical medicine, we're measuring things. We're measuring people's blood pressures. We're measuring their blood sugars. When we're treating depression, we measure depression. When we treat anxiety, we measure anxiety symptoms. If we're treating substance abuse, we have systematic ways of tracking, is the substance abuse improving? That's a very important concept to make this successful. The measurement-based care, again, and I've already made this point, so I'm going to go quick on this. Not everybody needs to be measured on the same things, but you have to establish what is the relevant thing for this client that we're going to track on, that we're going to measure. Because if you can't measure it, it's often very hard to really get substantial treatment change to happen when it needs to happen. I'm going to say a little bit, but I won't go very long because you'll have access to these slides, about this notion of having a computer-based system to help you track an entire population. So what we've developed is a tool that really is used for the care manager to keep track of the entire caseloads, to make sure their patients aren't falling through the cracks. And when the patient isn't coming back, that tool actually pings them and says, hey, you started a treatment here, but there is no follow-up recorded. Reach out to this person. And that's been a very helpful thing to be able to do. That tool also has some structured forms in it that guide patient encounters and clinical care in real time. So if a patient isn't improving, it might cue you to say, it's time to make a new treatment plan. And it also has a couple of reporting features in it. I'm going to just show very quickly a couple of screenshots to give you a more sort of a sense of what might that really look like. So this is not the same thing as an electronic medical record, because the record is a passive thing that sort of just writes down what you give it. This is something that actually processes this information and gives it back to you and says, here are clients where it looks like something needs to happen. It might, for example, summarize for you, this is a typical screenshot, what are all the contacts I've had, what were we treating, and what is changing in terms of the patient's outcome. It can give you a little snapshot about what are all the relevant things that are going on with this client right now. We call that a clinical dashboard. It can create a little summary for the primary care doctor that says, here's what we're treating, and here's a graph of patients' depression and anxiety symptoms over time, and here's the current treatment plan, and here's what my next appointment is. If one of our psychiatrists has consulted on one of these patients, we can say, here's a little note that the psychiatrist wrote that the primary care doctor can use to help make treatment adjustments. And we can also take that information and make a nice summary for the patient that the patient can walk out of a session with. This is what we did today. This is what we're working on. Here's your improvement over time. And our patients find that very helpful. So let me, in the last couple minutes, sort of cross over. We've sort of talked about common mental disorders in primary care. We've talked a little bit about patients who have, right in the intersection of mental health and specialty mental health care, very complex safety net populations. And I think there you really need to have systems that can reach across the divide and in a smart, coordinated way engage resources on both sides. And now I'm going to talk a little bit on what we do about the patients who are in our mental health centers, who are getting specialty mental health care, who really don't get good primary medical care. And I think this is actually the area where we have the least research evidence in. I can share a few facts there, and you all may know this, but there is now very good data that persons with serious mental illnesses are dying 25 years earlier than the general population. And suicide and injury account for about a third of this excess mortality, but 2/3 of these premature deaths are because these folks have untreated or poorly treated medical conditions, heart disease, lung disease, infectious disease. Speaking of lung disease, this is an interesting fact. 44% of all cigarettes consumed nationally are smoked by patients with severe mental illness. That's an enormous overrepresentation of what is probably the single largest modifiable risk factor for premature mortality today. And it's, these are our patients, that are smoking all these cigarettes. Several large organizations have looked at what we do to try to improve on this. A couple of years back, the American Psychiatric Association and the American Diabetes Association came out with a very nice consensus conference statement that said patients in our mental health centers who are getting antipsychotic medications are at very high risk for some of these bad metabolic diseases, cardiovascular diseases, diabetes. So they ought to be screened systematically for a personal and family history of these problems. We ought to be tracking their weights because this is a huge risk factor. Many of these clients are not just a little bit, but really severely overweight, and that is a huge health risk factor for them. Blood pressure should be monitored on all these clients because many of them have untreated hypertension. Many of them have strokes in their 50s or 60s, where patients who don't have mental illnesses might have strokes in their 70s and 80s. We ought to be tracking things like their blood sugar and their blood lipid profile. So that's the current recommendation. So the National Association of State Mental Health Program Directors took a similar look at this in 2008 and came up with a set of standards, measurements that should be taken on all patients with severe mental illness. And they're very similar. You can see them. I won't read through all of them. They include a few other things such as smoking and substance abuse. And they also include some process indicators. So they say that on a regular basis, clinics need to be screening and monitoring these conditions. And there needs to be access and use of primary care services for these problems. Now that's easy to recommend and very, very hard to do, and I'll say a little bit more about that. There is now a very large initiative that SAMHSA is sponsoring that has given grants to, I think, 13 and will probably give to another 9 mental health centers around the country to try to systematically improve on this. And on this slide is a list of measures that all of the grantees in this program are going to be asked to track on all of their clients. So very similar kinds of things: weights, blood pressures, blood sugars, lipids, family histories, personal histories of risk factors, and then probably most importantly on the bottom of this slide, how many people are actually getting care for this? How many of them are being screened for these conditions? Now let me say a little bit about screening. I'm going to use kind of a goofy slide here with a picture of a cow on a scale. And the point I'm trying to make is we have all started to become aware of this, and we're starting to think about what do we do, how do we measure all this, how do we screen all of this. And I'm going to sort of share with you a Chinese proverb that says something like, you can't fatten the cow by weighing it. And the point we try to make here is, I see a lot of mental health centers now putting in place ways to measure all this stuff, to screen all this stuff. And I supported an effort where several very good mental health centers have built very nice screening programs, and they're now systematically screening and measuring and all this stuff. And I'm going to say that I've never seen a case of diabetes that has gone away from being screened. Even if I measure your blood pressure 20 times a day, you still have high blood sugar. You still have a high blood sugar. So we are now in the process of putting in screening programs, but it's really not helpful to screen if you don't have the ability to take that information and really act on it. So I think we need to be thinking much beyond screening. We need to be thinking about how do we really treat. And treating diabetes is difficult to do in a non-mentally ill person. It's very challenging to do in somebody who has schizophrenia or bipolar disorder or a serious personality disorder. So it really takes a very robust approach to doing this if we really want to take that on and if we want to reduce that 25-year mortality gap. I'm going to share with you two more research studies very briefly here. One of them is a very nice study done by my colleague Ben Druss, who's at Emory. He did a survey of mental health centers, and he said, what is their capacity to screen and provide medical care? It turns out 2/3 of the mental health centers he surveyed had the capacity to screen for common medical problems. About half of them said we can provide treatment or referral for these problems. So that's down to half now. And 1 out of 3 said we have some medical services that we can provide on site. Now I would say that tells us that we've got a long way to go. At the end of the day, if we really want to make a difference here, we've got to be able to treat those problems for every one of our clients. So we've got a long way to go. I'm going to share one more study done by Dr. Druss, and that is sort of an effort that was done at a VA mental health center about 10 years ago that I think still is one of the best things out in the literature on what to do about this. And what he did is he built sort of the opposite of mental health in primary care. He took a medical clinic inside a mental health center for patients with severe mental illness at a VA. They had a nurse practitioners who provided the bulk of the medical services in this mental health center. They also had a care manager, and that care manager provided patient education and referrals. And they, in this study, randomly assigned 120 veterans with severe mental illness to getting this integrated care approach or to getting the usual care, and they followed them for 1 year. And what they found is that with the integrated medical model in primary care, they saw significantly increased access to medical care, less emergency room use, better preventive services, and it turned out this approach was actually cost neutral for the VA because, again, there are some cost savings if you do address those medical needs. I have a couple more comments. I know we're running short on time. Just to help us think about, now that we've looked at all this evidence, how do you really take some of these ideas and you build a program that works in your local setting? First of all, I would say, just looking back at what we just talked about, there is a lot of evidence about what works, and there's also evidence now about what doesn't work. I'm going to say just purely co-located care, for example, really there is not evidence that it works. So think about the core principles of the evidence-based programs that I mentioned, the measurement-based practice, the stepped care, the really collaborating rather than just co-locating. I think you need to have a very well-specified clinical and service model. I think you need to establish some measurable outcomes. You need to know, is this working? How would we know if this is working? Because if you can't answer that in a very clear, measurable way, all the way down to the individual client level, it's very hard to know, is this thing really working? And then you make program adjustments to achieve your desired outcomes. And again, I know I've probably said this about 4 or 5 times, but I really feel we've got strong evidence for this now. Simply placing a well-intended behavioral health staff in a primary care clinic, or vice versa, really won't get you where you want to go. The other thing we've learned is it's not easy to make practice change. So when we speak with clinics about implementing the impact model, for example, we now say there's a couple of steps we go through together. And it often takes a year or two for the organization really to find its way all the way through those. The first one are a couple of preparatory steps. The second one is a systematic effort to train all of the staff members. That's the primary care providers, the care managers, the consultants, the other mental health providers in the clinic on how do we work well together in this model. And then once we have everybody trained, we do a fair amount of implementation support that can go on for a year or two. And we also provide some clinical consultation on patients who are challenging in the model, because that's what really helps organizations put this in place. The first step in this is usually what we recommend is using a systematic process to build your clinic's unique collaborative care team. And we say we start with having all your staff doing an assessment of what they do now. Then we identify some gaps. Oftentimes you have some duplicated services, and you have some things that everybody thinks somebody else is doing, but nobody's really doing it. And you can identify that in a very systematic way. Then we help generate a kind of a new workflow and a plan on how we're going to make a change. And then we do look with you and sort of see, are we actually finding our way to making these changes and our patients getting better. The last thing I'll share here is a little systematic tool that we've developed, and we'd be happy to share that with you. It's on the AIM Center website, which is on this slide here, that gives you a good start when you're doing these assessments. You know, sort of takes the tasks we have in integrated mental health care and it breaks them all down into a number of tasks. And it then says, each staff member says, is this something important? Do I do this now? If I don't do it, who else does it? Could I do it? Would I need training to do this? And then you take all these assessments and you put them together, and now you start saying, you know, where do we have the duplications? Where we have things missing? And you really start building your own team using this kind of an approach. I'm going to conclude with two references. One of them I'd like to point out is a really nice summary compendium on a field of integrated mental health care that Lori Alexander helped together at the Hogg Foundation, and there's a website that you can download from and another article. Thank you.
Great. Thank you so much, Dr. Unutzer, for that great overview of the research evidence on integration models. We're now going to turn to audience questions. We have about 20 minutes for questions, so if you wish to submit one, simply type your question and click submit in the dialog box that you see there. Okay, and we do have a bunch of questions that we've already received. The first one was, in discussing integrated services, you were speaking of patients that have co-occurring disorders, which include mental health, substance abuse, physical health problems, etc. Is there also any way of integrating services for alcohol or other drug patients who may have only a transient mental health problem and not necessarily a chronic mental health disorder?
I guess since it's a written question, it's hard for me to ask for a little more context. So, you know, oftentimes we have a need to integrate across all three. We have populations that have all three problems. We also, of course, have populations who have primarily an alcohol problem, but then, you know, develop a pretty significant depression or some anxiety in that context. We have patients who have any of the two of the three, and I think you could think about integration in any setting. In a pure substance abuse treatment setting, you want to be thinking about what do we do for the patient where treating the substance abuse is not enough. They have a severe depression, they have anxiety, they have maybe bipolar disorder. How do we integrate mental health treatment? And I think we know a little bit less about how to do that, but I think the same basic principles apply. If you work backwards from where your patient is at, you know, if they need medical treatment, medication treatments, or psychotherapies for, you know, for severe anxiety or for depression, you need to either say, can we bring that on site and build a shared workflow, or can we coordinate better with another organization? I think you can take the same basic principles and think about how to do that. The other thing I might refer you to is that little overview slide where I put together where we see overlap between treatment for depression and treatments for alcohol, and how you might array of service that really can address both those things. I think it was somewhere in the middle of my slide deck.
Thank you. During your discussion of collaborative care, you talked about the role of the consulting psychiatrist. The question is, would psychiatrists be reluctant to make treatment recommendations without having actual contact with patients?
Yeah, that's a fabulous question. So this is not what most psychiatrists have been trained to do. So most of us are trained to sort of do one-on-one. You know, I go and take a client and I close the door behind me and that client, and we do a very high-quality interaction where I do, you know, an interactive assessment of what's going on. Here I'm doing something very different. I'm providing consultation based on the report of a couple of trained professionals, a primary care provider and or, you know, a mental health provider. And, you know, that's a little bit different. You know, I'm in a sense providing backup. Now, when we make those consultations, we always say, and we have a little statement that makes it very clear when we write the recommendation, I have not seen this client. I'm giving you some advice based on the best information that I've been presented. So we're never going to pretend that we actually saw the client. But oftentimes, the things that we can say are pretty straightforward. It's not that complex. It works in a setting where you have a lot of structure, where you have measurements, have a care manager who's trained to report to you in a very systematic way what's going on. In that setting, I'm pretty comfortable making that recommendation. Clinically, what this is like is, you know, I work in a big academic medical center here, and I get asked a lot by other physicians here and by specialists, hey, I have this person who's got this and that. What do you think I should do? That's what's called in the business a curbside consultation. And I'm going to say, I haven't seen the client. From what I'm hearing, here's some thoughts. Or I might say, you know, I need to see your client. Or I might say, I need to have a couple more pieces of information before I can really do that. So with all these caveats, actually, it's quite possible, and you can find psychiatrists, especially psychiatrists who've trained in consultation liaison psychiatry, who are pretty good at this. So will they be willing to do it? Not all psychiatrists like doing this. Not all psychiatrists are comfortable with doing this, but we have a large number of psychiatrists now in the Diamond Project in Minnesota, in our mental health integration program here in Washington, and in other settings that really are, you know, pretty comfortable doing this, given the constraints of what it really is.
Thank you. This was a question about the impact study. Very briefly, how many of the patients that were studied would have had a diagnosis of mental disorder due to a general medical condition? The question is asking that because that type of services would not be reimbursable by Medi-Cal.
Yeah, all the patients in the trial met criteria for major depression. And they might have had also, most of them in fact, the average impact participant had 3.5 other chronic medical conditions. Some of them have as many as 5 or 6. But they all met diagnostic criteria for major depression. So, and they, in fact, we did research diagnostic interviews, which are very structured, very systematic, and so they were not felt to be due to a general medical condition. There are people who have major depression that's exacerbated by having diabetes and heart disease, but it's not caused by, they have a diagnosis of major depression in and of themselves. So Medicaid would have paid for all those patients' care.
The next question is, in collaborative care, do the mental health patients actually receive individual psychotherapy?
Yeah, that's a great question, and I went very fast over that. In fact, I skipped that. So our care managers in the impact model are all trained in brief evidence-based psychotherapies. We train them in an approach called behavioral activation. That is a brief behavioral treatment that comes from work by Lewinson and colleagues, started in the 1970s, and more recently psychologists like Martels and others have really written nice manualized approaches on behavioral activation, activity scheduling, and other techniques. We've trained all of our care managers in providing that. We also trained our care managers in another brief psychotherapy approach called problem-solving treatment, or PST. The care managers in the impact model can offer the patient right there in primary care, 6 or 8 sessions of one of these brief structured psychotherapies. In fact, in the impact model, what we would do with a typical client, we would say, you have this severe depression, there are two ways to try to treat that. The doctor can write an antidepressant medication, and I'll support that, and I'll work with you to make sure that you tolerate that well. Or we could do one of these psychotherapies, and oftentimes we find we end up needing to do both. And the patients were really encouraged to make a choice. So some patients started with an antidepressant. Other patients said, I don't like to take another pill. I've had a pill, it didn't help me. I really want to do some of these problem-solving sessions. And then we would do 4 or 6 or 8 sessions. And if the patient was all better, then we're in good shape. If the patient was not all better, we might say, hey, this seems to be helping, but maybe we should think about adding a medicine at this point. So it's a nice thing to be able to offer both. So yes, psychotherapy is a very important part of this. And we have had, since the trial, had people come to it and use other therapies. So if you have a therapist who's very good at cognitive behavioral therapy, or is very good at interpersonal therapy, those are structured, brief, evidence-based psychotherapies that can be substituted for, say, the problem-solving treatment. So it's a very good question. I'm glad you brought it up, and it's definitely an important part of the model. One of the big differences is, it's easy for the doctor in primary care to write a med, but it's not easy to say, gee, I'd like for you to have 6 or 8 or 10 sessions of really good psychotherapy. If they have a trained staff member in their clinic who can do that, then all of a sudden you have access to that. Great.
Thank you. Thank you. Another question about the impact model. On average, how much psychiatrist time is needed to implement impact?
Yeah, I can comment on that. I'm going to say a typical care manager in impact would support somewhere between 4 and 10 primary care physicians. They might have an active caseload of anywhere between 75 and 100 patients, and it would take about 2 hours, maybe if it's a really serious, if it's a safety net setting where patients have lots of needs, maybe as much as 4 hours, but more typically 2 hours of psychiatrist time per week. And that time is really spent, doing 2 things. The first thing is every week we would have an hour where the psychiatrist would either meet with or talk on the telephone with the care manager and say, I need to go through every single case you have who's not improving. Weigh in on that and make recommendations. And the other hour might be, we've talked about a complex client several times. I don't know what to say. I need to see them. So next time I come, I'd like to do my own evaluation. Or it might be spent consulting directly to one of the primary care providers. So I'm going to say 2 to 4 hours a week, a good implementation of the model.
Great, thank you.
So in a setting where you have relatively healthy insured patients, it can be done, like the Diamond clinics in Minnesota, for example. It can usually be done in 2 hours. In the mental health integration program here in Washington, we budget our psychiatrists to be available to a clinic for 4 hours a week. A bit more needs and evaluations. Patients are just so complex that it does take our psychiatrists more time to really make meaningful recommendations.
Very good. The next question is about the registry. And the question is, how does the care manager's registry interface with an EMR?
That's a great question. In the ideal world, the EMR has the capacity of the registry built in. There are some electronic medical record systems today that say that they have registry functionality, and some of them have very basic registry functions, so they may be able to give you a list of all the patients who have depression. They don't tend to be very robust. So what we have found in most cases today, even in some very large organizations that have sophisticated record systems, our care managers often use a freestanding computer-based, often web-based registry, and they will use that to support their workflow and then use it to generate little notes that they can then insert in the patient's medical record. So the web-based registry tool that we support, for example, you might generate a note in that as a care manager, and then there's a little button that says export this as text, and then they would take that, paste it into the patient's record so it's available to the primary care provider or anybody else who needs to see that. I think that we're going to see a lot of change in this area over the next 10 years. Some of the better EMR tools will build out really registry capacity. In the short run, I think we will often see care managers using registry and finding ways to just transport that data into the EMRs.
Great, thank you. Next question pertains to confidentiality. What are the confidentiality issues with integrated care, and how can they be addressed? It's kind of a big one.
Well, though, it's an important one. I'm going to say a couple things. I mean, from a legal perspective, this is basically handled by HIPAA. I know HIPAA is very clear about when you can share, under what circumstances you can share information about a client with another medical provider. You know, and basically, I mean, we could do a whole hour on HIPAA, and some of you know probably more about it than I do. Basically, if I'm a treating provider and I'm communicating with another treating provider, and it doesn't really say what type of provider that is, I can share information. You know, I don't share a lot. I share what's needed for that other provider to do their job well. There are really not important barriers. I think there are a lot of myths around what's possible or what's not possible. I think oftentimes when we talk to our colleagues in primary care, their number one complaint, besides they don't have access to mental health, is when the patient does go to mental health, we never hear anything back. You know, and I have had several of my colleagues in primary care say to me, I think you're just hiding behind this confidentiality thing. You know, it's not helpful for me to send the patient off and they go into a black box and I just don't hear anything back. So what we encourage organizations to do is we would say, you know, when you're a primary care provider and you're involving a care manager, you're involving a mental health center, you talk with your client about it. You say, we work here together as a team. I'm going to be sharing your information with our care manager, with the psychiatrist who consults to us. If you're going to go over to a mental health center, I'm going to be sharing information with them. And I have never heard of a patient complaining about that. You know, I have heard many times where the patient says, why don't you guys talk to each other? I have not ever met a patient who sort of said, why did you talk to this other provider about my care? But, you know, from a legal perspective, I think HIPAA is very clear on what are the circumstances under which we can and can't share.
Great, thank you. Next question is, what can you say about using the impact model in a substance use treatment facility?
I can't say very much based on research because it hasn't been done yet. We have trained a number of providers who are doing the SBIRT model, you know, screening and brief interventions for substance abuse in primary care. We have trained a number of providers that are doing that model in also offering impact care management in a primary care setting. And I think, you know, we've not studied this formally. We've not published research on that, but I think that is actually, that can work pretty well. We've not implemented the impact model per se in a pure substance abuse treatment facility. That research would have to be done, and I'd be happy to think about it, talk about it. I mean, I would basically do something very similar to what I showed. I'm going to go back through my slides here on this. You know, I would sort of say, what are all the tasks that need to be done? You know, it's pretty straightforward. To do good depression treatment, for example, there's a bunch of things that need to happen. Now let's look and see, what does the center provide already? Who is what? And what else do we need to add in? What do we need to bring in? And so I would just use a systematic approach to trying to build it up. And then I would say, let's measure people's depression scores using the PHQ-9 every time they come in. And then either it'll work or it won't work. If it doesn't work, we have to take a step back and say, you know, how would we have to do it differently? But again, there's not research data out that tells us it works and how does it. We'd have to draw on what we know and kind of put it up and really measure it and see, does it really work?
Very good. We have time for just a couple more questions. The next one is, in reference to clients with schizophrenia or bipolar disorder, where does the most effective integration happen? Is it in a primary care setting or a behavioral health setting?
Yeah, that's a very good question. I'm going to say patients who have schizophrenia, I am not aware of very many primary care settings who are comfortable with and well set up to treat that. We certainly diagnose it in a primary care setting. Patients often present there initially. But long-term treatment, I don't think, there are a number of patients who have really significant medical disease, especially when you have older patients, so patients who have, COPD, pulmonary disease, who have bad heart disease, who need so much medical care that de facto often their schizophrenia treatment starts happening in a primary care setting. So I support several primary care clinicians who've got pretty good caseloads of schizophrenia patients, in their diabetes clinics, in their heart clinics, because at some point, especially when the client gets older, that can become such a big issue that they're in the doctor's office a lot. And then you start also thinking about, couldn't we also prescribe their antipsychotic meds? But by and large, I would say with schizophrenia, we're much better set up in a mental health, specialty mental health setting to care for them. They have a lot of, those patients have a lot of rehab needs. They have a lot of social support needs that you're not really well equipped to meet in a primary care clinic. Having said that, these are the folks where we really have to think about how do we help address their medical needs, because if we don't do that, they're going to die when they're 50, when they're 45, and not when they're 70 or 80. And they're not dying because of their schizophrenia. They're dying because they have literally untreated hypertension, untreated diabetes. And our colleagues in primary care look at this and they're just appalled, because they're saying, nobody should die today from untreated high blood pressure. That's totally treatable. Bipolar disorder is interesting. There are clearly bipolar patients, again, who are much better off being treated in a mental health setting, especially those who have frequent hospitalizations, who are very unstable. We are seeing, though, in our integrated care programs, large numbers of not sort of really, really severe bipolars being treated pretty well in an integrated care model in primary care. For example, in this mental health integration program here in our state, we have treated about 12,000 clients in this integrated care model over the past 2 years. And about 300 of them have been primarily treated in mental health centers, and about 1,000 of them have been able to be treated pretty successfully one of the health centers. The bipolar disorder, I think it's sort of somewhere on the interface. And you have to make a decision for each individual client, where is it really, where are they best served?
Very good. Dr. Unutzer, I wonder if you could just very quickly answer the last question, which is actually quite a big one, but if you have any final thoughts on this. We've received a couple of questions that basically get at the point of how on earth can we do any kind of integrated care in our current budget crisis environment? Any things that you could say about what people could actually do given the severe budget constraints that they're facing?
All right, so that's a big one. If I could take a step back from like the acute crisis, I would say if there's ever a time to think about integrating, this is it. Because any of the integration efforts that have been well done, actually what they show us is it's cheaper to give integrated care than to give siloed out care, because there's so much duplication, there's so little coordination. So if the states were smart, this is the time to say, wait a minute, I'm not going to give a little bit of money, suboptimally fund 8 silos. I'm going to try to say, can we create a stream of money that follows the patients through these various settings and that reduces some of that duplication. So if there was ever a time to say, gee, we don't have enough money to serve these clients' need well, let's do something that's better coordinated, more integrated, I think it'll actually save money. Now, that kind of thinking may be hard to do when people are totally stressed out. What I see happen is in a typical crisis, every one of the silos says, whoa, they're trying to take my money away. they shore up their walls. They'll say, I'll ride this out somehow. I'll make do with it somehow. And at the end of it, we still have the same system. So we have had several examples in our state here. For example, the mental health integration program actually, I think, has taken this on. They have said, look, these are complex patients. They're very expensive. Let's do this kind of an integrated benefit, and it may actually be better for our clients and cheaper in the long run. So I think in some ways, if there is ever a time to say, can we do better and can we do it more efficiently, a time of budget crisis might be the time.
Very good. Thank you, Dr. Unutzer. I'm afraid we're out of time and have to leave things here for today. Our thanks to more than 200 of you attending this second webinar in our 6-part series, Integrating Primary Care, Mental Health, and Substance Use Services. Your questions will be posted as FAQs on the CIMH website at the link you see on your screen. I would also like to thank Dr. Unutzer again for his excellent presentation on the evidence base for models of integrated care. This webinar was recorded and will be posted on the CIMH website at the link you see on your screen. The slides that he presented will also be posted there, and you should have hopefully received them by email earlier today. Our next webinar is on May 6th, and will focus on creating partnerships that support integrated care. To view the webinar schedule or to register for a future webinar, go to the link you see on your screen. Again, you may want to print this PowerPoint slide for future reference. Please note that you must register online for each webinar you wish to attend. So just because you signed up for today, it doesn't mean that you're signed up for next week's. Again, thank you all and have a great afternoon.